Okay, we're going to get started so that we can get finished because people have got trains to catch and places to get to. And so we're just going to compress this last little bit. But the Network of Excellence 2, we've just got feedback from the NHS Genomics unit about which things they want to take forward. Very much aligns with what Sue was saying right at the beginning of the day around some of the specific health challenges that have been highlighted in the 10-year plan. What we're going to do is talk, I'm going to invite a couple of my colleagues who are going to lead work packages in the next network just to come up and give a little bit of a flavour of some of the work they're going to do. And then once they've just shared, I'm going to talk a little bit about a new project and programme that we're hoping to establish and set out the scene for that. And then we'll take a couple of questions and then we'll round off the day. So I'm going to invite Elvira Brahman, who's our colleague here in London, who's expert in pharmacogenetics and mental health, just to talk a little bit about her work and her proposal for the next network. So Elvira.
Thanks so much for inviting me and for the kind introduction. So I'm Elvira Bramon, I'm Director of Psychiatry at UCL, and I have been working informally with the network and enjoying it very much and learning lots about other fields like cancer and, aminoglycosides in babies. But hope I can get this to move along. Yep. So we've been running a study called GEMS, looking at the pharmacogenomics of severe mental illnesses like psychosis. And basically, we've been recruiting patients with a diagnosis of psychosis. 600 of them, we've already offered them a pharmacogenetic test and have given the results to them, to their clinicians and themselves. And the rest is the other. Sorry, I'm just trying to use the pointer there. So we're comparing them against a group of people who receive treatment with antipsychotic drugs in the usual way, so that's empirical prescribing. And then we collect a range of economic and clinical outcomes. So the study has been funded by the NIHR and the kind of funders that you see here. And the side-by-side network is a group of people who have lived experience of severe mental illness, who have been advising us all along from the design of the study from day one. And we've recruited, as I was saying, 605 patients so far. We've also recruited a lot of clinicians, because, of course, the behavior of the clinician is very important to us as well, as was being said earlier in the morning. And the study recruits all over England and Wales. These are the sites that have been more formally involved in the study. And there was meant to be a map, but because of the bright light here, I don't think you can see the map, but hopefully you'll be able to see the rest of the slides. So diversity has been touched upon. It's really essential. So the study obviously includes all ancestries, and we've done quite well in that about just over a third of our participants do not identify as European. And the ancestries you can see on slide, it's a wide range there. This is about double the rate that you'd expect from the census of England. So we're very keen. We're prioritizing them, basically, to make sure that the study has a balance. And of course, the age range is very wide. We are very keen to start testing teenagers and bring the age down now that we've got already a lot of experience with adults and a good gender balance, as you can see. So these are results from the PhD of Lauren Verney, who is sitting here somewhere, I think. And basically, in this sample, because they've been recruited in secondary, in specialist mental health care services, these are patients who are relatively complex. So there's quite a lot of combination treatment. So 40% of them take an antipsychotic and an antidepressant combined. And of course, there's a question that I think was being raised earlier on, and how many people can you actually help? And we can really only see this if we do studies like this one. So very fortunately, if you use a panel of genes like you see on screen, which is the kind of panel that you would use for mental health, then you see that the majority of patients, 86% of them, have one or more actionable genetic variants. And in fact, about a third of participants have two. So how do we define these? We call actionable having a genetic variant that has a clinical guideline to inform one or more mental health drugs. And clinical guideline could include CERSI or CPIC or the Dutch pharmacogenomic guidelines. I think you won't be able to see the slide fully. It would be nice to maybe draw the curtain. I don't think you can see this very well, but you get the gist of it. So basically, this is, again, data from one of the colleagues in the team, Maria Richards-Brown, which I'm not sure why the pictures are not showing. It must be the bright light here. So anyway, so the MARS is a scale that's been mentioned earlier before. It's self-reported adherence to medication. It asks questions about whether we forget to take our medications and things like this. So the higher the MARS, the higher the adherence. And on the x-axis, we've got the CYP2D6 activity score. So we found an association whereby people, as the activity score increases, the adherence increases. And it kind of makes sense. It's what you probably would expect to find. Adherence is a very complicated behavior. I'm not reducing it to be influenced by a single gene. Of course, I'm not saying that. But there could be a link with side effects, which is the next slide. Yeah, I put some. Now I see where the pictures weren't loading. So this is another a possible explanation why we find these links with activity score on CYP2D6 and adherence. So in this case, we're looking at side effects to antipsychotics measured by the Lanza scale, which measures both the frequency and the severity of side effects. So as you can see, people with a low activity score have more side effects than people with a high activity score. As you would expect, it's not as surprising. It's almost like a proof of concept finding, but it could be part of the explanation why there's also changes in adherence, whereby lower activity score is affecting adherence. And of course, as I was saying, we're very keen to look at clinician behavior. We all know, I'm a clinician, so we all know we don't always follow guidelines. We try, but we don't always follow them as we should. So this study, this analysis looks very roughly at what the clinicians are doing after we've given them pharmacogenetic information. Half of the time, so these are all clinicians, mostly psychiatrists, some mental health pharmacists, treating people with psychosis routinely after they've received a pharmacogenetic report. You can see on the right-hand side, half of the time the clinician is not changing the medication at all. And here, of course, here we've looked at only 2 genes for simplicity because it was becoming very complicated. So we looked at the 2 main genes, CYP2D6 and CYP2C19. Sometimes, obviously, people are normal metabolizers on both, so there would be no expected change. Most of the time, the clinician follows the pharmacogenetic recommendations. Sometimes they don't. That's fine. When the clinician changes the medication, that might mean they change the dose or they actually change to a different drug. We have more than 20 antipsychotics, more than 20 antidepressants, so changing drugs for us is completely normal. It's part of our jobs. So when the clinician changes the treatment, again, you find some people where that's absolutely fine. They don't have genetic variants. Almost 70% is aligned with the recommendations, and 15% of the time, 15% of the prescriptions are not aligned. So that's quite reassuring because the last thing we want is for clinicians to follow the genetic guidance too strictly. We want them to think holistically and to think about other things, medication history, patient preference, comorbidities, and sometimes how unwell patients are. A genetic test might say, you're a poor metabolizer, reduce the dose of the aripiprazole. That's all good, but if someone's really unwell, you cannot do that at the time. You have to wait and do it when they're better. And we've also done a survey of clinicians just to see what was happening. And we just published it just literally in January, and it's led by Daniele Panconesi. So this is just one of the questions that I thought would be interesting to show you, which is what stops a mental health clinician ordering a pharmacogenetic test? I was expecting they would say, because I don't have access to ordering it, which is true. Like we don't have access to these at the moment in routine clinical practice. But that's what they answered. 42% felt that they didn't have enough knowledge. And most of the other answers that you see, like little or no or uncertainty about the value, not being familiar, not being applicable, it's the pattern of lack of confidence, not knowing. So there's some training that is required here, clearly. What is good news, though, is the last bit in green. Clinicians don't think that the patients would, very few clinicians think the patients would object. And that fits with our experience, that patients are quite keen to have pharmacogenetic tests. And of course, to address this lack of knowledge or lack of confidence, we're very happy to be involved in the Genotes program. We've done some articles for Genomes, which is a fantastic program for a genomics training for NHS clinicians. And then finally, I'm on 7 minutes, so I hope Bill is going to be happy that I'm not making his presentation rushed. So I just wanted to mention what's happening next in the network. We're really delighted to be part of the second round of the network. And I have to particularly thank Dharmisha Chauhan and Paul Reeves, because thanks to them, we didn't miss the deadline. So we were able to be in. And so this is a collaboration between the centres that you see here, the North Thames Genomics Medicine, East London NHS Foundation Trust, a company called Edge Health that does health economics, and UCL. And thank you so much for your attention. Our next focus will be on health economics of this data. Thanks. 8 minutes, 8 minutes.
Perfect. Thank you so much, Elvira. So it's going to be great working closely with you. I'm just going to ask Emma and Ramona if they'd like to come up and just say if there's anything they want to say about their work package.
Do you want us to go now?
Yep. No, you go now, and then it'll be me. Yeah, is that all right? Or have you got your slide? Have you put it up?
Slide is on another thing, so
Oh,
we
no.
can talk, but us talking might make more sense after you talk.
Okay, let's do that. Okay, I'll be quick. Right, so Network of Excellence is starting on the 1st of April, version 2. I'm going to co-lead it with Charlotte Skidrell, who's here, who's a pharmacist in Manchester that a number of you know. So I think that's great to have that leadership with pharmacy, medicine, etc. And here are a number of the programs that we're going to take forward. So the first program, I'm not going to give too much detail on because this is still a little bit of a work in progress, is going to be quite laboratory focused. So there are a number of questions around what type of testing we should be doing in pharmacogenetics. That's a bit of a movable feast about which genes, which variants, which technologies we should be using. I think I saw Jess, there is Jess Woodley and colleagues from the ACGS have been starting to think about this with some of the labs around the country about variant interpretation. There are a number of initiatives across the world that are looking at that, so bringing that together. And then as Sue mentioned right at the beginning of the day, there's whole genome sequencing being generated within the NHS, and how do you extract data from that? Can you do it bioinformatically? I think we can. It's just a question of setting up that pipeline. It's then what you then do with that data, how do you surface it, how do you make it available, and some of the things that John and Vidya have been talking about. There's a work program around mental health pharmacogenetics. You've just heard from Elvira. I'll tell you a little bit about some of the work that we're hoping to take forward. Catherine, who you've heard from earlier, is going to be working very closely with us around some of the health economics evaluation of some of the work that we'll be taking forward around the mental health pharmacogenetics, but some other work. And Paul Wilson, who we've worked with very closely with Lisa and Amy, are going to be helping us with the implementation science work. We've got a specific health economic analysis with Guru Athul, who's a clinician who worked for a number of years up in Newcastle, where Anne Daly did some work on drug-induced liver injury associated with antibiotics, particularly flucloxacillin. And so we're really keen to explore, should we be doing testing around that, which groups of patients we should, how could we use that information? And Munir's got some very helpful insights into that. And then Munir has already told you about the program of work around CERSI. We're delighted to be able to support some of that work, particularly around taking the guidelines forward. And one of the aspects is that we're very keen that rather than those guidelines just being available as a PDF or a paper copy, that you can digitalize them, create APIs, and so like CPIC guidelines, they can then be interrogated and used and linked into clinical decision support. So that's something that's a really huge piece of work, but we're going to start doing some exploratory work around that. Emma and Ramona are going to tell you a little bit about some of the patient voice and public engagement work that we're hoping to take forward. And then, as you'll have seen, there's still quite a lot of work to finish off from Network 1. So we're not just stopping. We're going to make sure that some of the progress work, Munir's continuing with a lot of the work in the cancer program. There's a number of other pieces of work that we want to carry on, find other funding streams for. And one of the things that we have done in Network 1 that we absolutely want to do in Network 2 is to ensure that we are open to work with colleagues around the country who have got ideas, and we have no ownership of all your ideas and your projects. We just want to be aware and support them where we can. Okay, so I'm going to tell you a little bit about one of the programs that we're going to take forward in Network 2. You'll have heard through the course of the day, there's a number of guidelines that are out there from the States, from Dutch Working Group, and now being developed in the UK through the CERSI program. And there's strong guideline evidence around drugs that are used in treating patients with depression and anxiety. You saw the figures from Porrig and Cynthia that showed that anxiety and depression were the first and the third most common problems that people described within the CPRD data that they've been prescribed medication for. There are 9 million people in the UK that are on antidepressants. About 500,000 people are starting antidepressants every year for the first time. Most of that happens in primary care. The cost is large. It's £200 million a year on the medication. Individual antidepressants don't tend to be that expensive, most of them, but the biggest cost is in terms of the health impact on individuals, both at a personal level in terms of cost to the NHS and cost to society in terms of employment, etc. And so it's a huge problem, something that the NHS has wanted to tackle, and pharmacogenomics may be part of rather than the whole answer. So to give you a bit of sense of the background to this, there's no UK primary care study of pharmacogenetics in primary care. There's no UK health economic analysis. There are lots of studies in this space, but they're very variable in their quality, in their size. Some, a randomized controlled trial of 51 patients is not going to really tell you very much. Very few of them included patients with anxiety. As I said, very few in primary care, and very few, as we'll come back to, where there was data available prior to prescription. So this point that John mentioned earlier, that you prescribe someone, you then do a test, or you've got the results at some point later, and then do you switch people, rather than actually having that data up front. So as part of the PREPARE study that you'll be aware of, we've touched on, that Munir and colleagues in the UK were part of, they've done a sub-analysis within Greece. Of course, PREPARE was only focused on adverse reactions, but you can see that there's some benefit in using pharmacogenetic data in the context of reducing adverse drug reactions for antidepressant medication. It's not just all about effectiveness. So we are designing a program because we're into racket sports, like baby tennis. We've called it padel. So this is the pharmacogenetics of antidepressants, economics and life outcomes. We're at a very early stage, and I'll touch on that in a minute, but this is going to be a primary care study. It's going to take a lot of the learning that we've got from Progress, which I'll touch upon. We want to make sure that this is absolutely reflective of the UK population, so ensuring that we have recruitment across different populations in terms of socioeconomic status, ethnicity, age, and sex. And we're proposing at this stage, we think that we will go for what's called a step wedge cluster randomization approach, which is basically each site will start off not using the pharmacogenetic data, and then at some point through the course of the study, they will start using that. There are lots of different ways you could approach this, but I'll tell you why we think that this might be the best way to do it. It will mean that eventually all the sites, all the GP practices will be using that data, but they will become their own internal controls. around that, so you've got some comparison data. And one of the drivers for this is because Ron, who was here earlier, that number of you know very well, is a real force in pharmacogenetics across Europe, has worked very closely with our colleague Jessie Swen from Leiden, who was the lead author of the PREPARE study, and they have got a program of work called P4 Care, which is essentially a funded program which is due to start recruiting in October this year. And we want as much as possible to align our studies so that they are as similar as possible, so that then we can combine the data. So that's one of the drivers around using the same step wedge approach. They were ahead of us in terms of designing their study. As I said, there are different things you could do. There will be clearly some elements that are UK specific, so some of the health economic aspects, some of the implementation science aspects, but as much as possible, if we can unify our approach using the same variants, the same entry criteria, the same analysis approach, we won't run into some of those problems where you end up doing sort of messy meta-analyses to try and bring things together. And we'll hopefully have the power that we require. So as you saw earlier, we've got some confidence that this will be achievable because of our experience from Progress. So nearly half of all the people that took part in Progress were started on an SSRI. We know that there were 5 or 6 practices in Progress straight off that are already committed to participating in this program that recruited over 100 individuals, and some of them very quickly. So that was great. We described to you the Progress RX way that we would introduce the information back into the electronic records. We're probably not going to do that for this. Well, we're not going to do that for this. There's no probably. We just don't have that available to us. So that's not an option. But the Geno approach that we used, we know works well. It's not the tool that we would use moving forward for scale, but in the context of this study, we think it will allow us to do what we need to do, and it's got all the regulatory approvals in place. We know that the turnaround time that we've got in the laboratory that we've done for Progress, and the team have been working very hard on a new type of genetic testing that we will move to, that should fit in with the clinical pathways. There's a little bit of work to do there. And then approaching people through e-consenting, which we shifted to in Progress rather than doing paper consenting, worked very well as well. So we've got lots of confidence that some of those things work well, but there's always new things that crop up. So we're about to move in our laboratory away from using a GINA testing to a Thermo Fisher base test that allows us to do a single base test which captures copy number analysis, which is really important for CYP2D6, etc., rather than having to do the 2 assays, the GINA test and the digital PCR. Through Progress, we've generally taken saliva samples. We're going to explore whether we can do a cheek swab analysis, because that might be a little bit easier, but we need to do some work there. In P4 Care, they're not just reporting back the variants that are absolutely associated with the antidepressants. Going to report back some other genes, which you know, you can see VCORC1, SL01B1, are not associated with antidepressant treatment, but the additional value of doing that panel, they call it their PGX passport, and we're going to speak to them about whether we should do that as well, and just seeing, but I think that's probably going to be a sensible thing. What they say from some of the work that they've done is that a lot of people with depression and mental health problems, Vera will know, have other health problems, and a number of those they're taking other medication which is relevant to pharmacogenetics. And so there is an added value in having that broader range of genes. So that's something that we'll consider. But we don't want to be distracted from our main question. But when there's added opportunity to ask other questions, we should do that. So we're going to aim for people who are treatment naive. So that means that they've not had an antidepressant for a year before that, so they might have in the past at some stage, but they've not been on an antidepressant, and then you're starting them on one. It's going to be adults. We are going to try to see if we can recruit people when the result is available. So the doctor will have the discussion with the patient. Are you prepared to wait a week for your results, and then you make the decision. Now, there may be some patients that don't want to wait a week, and that will be something that, of course, won't be a study breach. It will be allowed, but we will try to encourage people where that information is available, because we see that from our data so far, that the prescription is changed or is modified on the basis of having that information rather than changing people once you've already started on something. And we've got a lot of work to do to capture patient-reported outcomes and make sure that the outcomes that we're measuring are meaningful. So aligning those with the Dutch study, we'll be looking at treatment remission over 12 weeks, so both for depression and anxiety, but also, and this will be work that we'll be discussing with Catherine over the coming weeks, about how you capture healthcare consumption over a 12-month period. Lots of work to do on the statistical analysis of the data. Step wedge trials are complicated to analyse, but if you know that at the beginning, you can prepare for that. We will seek adoption onto the portfolio. One of the things that's been great in progress is that we've had a lot of engagement from the associate PI scheme. So pharmacists have been really taking a bit of a lead here. There'll be some costs to support sites to get involved. We will aim to have this study open January next year. So there's a lot of work for us to do to get everything in place over the next few months, and then as we've done through progress, making sure that we're in constant contact with the study sites. Eva and Nicola, who are here with some of their colleagues, have done a lot of work, and we know that's worked really well by having that constant engagement, being available, and making sure that this is seen as a study, not just a Manchester thing. This is absolutely like progress, where we want you to feel, and the pharmacists from around the country and the GMSAs have been incredibly supportive, helping us to find the right practices, to get people on board and to engage. So we're really keen for that to happen. So start having conversations with practices in your region that you think might be interested, and then we'll get back out to you, and then we'll set up a study advisory board. We've got some great people already who suggested that they'd be happy to be involved with us. So just running alongside that, as we've done with Progress, we're going to have Catherine lead on our health economics work. We've got Paul and his team going to run the implementation science work, and then Alison, who's here, who I had a few words with earlier, and her colleague John at King's College, doing some great work in behavioural psychology, understanding how valuable an intervention is into changing people's behaviour. So are people more likely to stick with their medication and be adherent if they've had a pharmacogenetic test, irrespective of the result, or based on the result and all the other elements that go with that. So I think that'll be a really valuable study to supplement it. So I'm going to stop there. I'll let Ramona and Emma come up now, and because that might be helpful. And then we've got 6 minutes. That's okay. Ramona, Emma, do you want to say anything?
I had a slide, but it was attached to other slides, which seemed complicated. So essentially, thanks so much for letting us tag on to that. We were thinking that because there's the opportunity to integrate patient attitudes and patient-reported outcome metrics within the study design for this new study in terms of implementing pharmacogenomics in psychiatric medicines, well, antidepressants within primary care, that we would focus on that mainly. So three-prong approach. One, something fast that we can do is recall some Progress participants and try to understand their experiences. And that's quite a nice lead-in to working within the design of the new study, PEDAL, because there was no script or curated patient return of information within Progress. So I think we can understand from them first with some mixed methods how that experience was for them, what they would like, what they wouldn't. And then within the PEDAL study, we were thinking, one, we can work to really enrich underrepresented populations, either from an ancestry or socioeconomic perspective, hopefully both. Two, we can incorporate patient-reported outcome metrics and understand the patient experience throughout, pre, during the return of information and care and after. And four, we can potentially curate how information is filtered back to patients within this study. So having perhaps scripted information in terms of returns of results within any communications to patients and standardized patient materials. And that can all be built into the protocol. So I think a real opportunity there. Is that about right? Ramona can contribute something further.
This is the most stressful slot anyone can have. If I start talking, I'm a bit scared that my enthusiasm will take over and everyone will miss their trains, myself included. So it's really, really a great privilege to be part of this working package and work with everyone. And I think everyone sort of mentioned this already. The opportunity we have is not just obviously do this work, but build on the previous network of excellence and build on the work that we have done with PALO or Progress or CERSI, and all the information we have, and mainly all the questions we have from the previous studies will hopefully have a great opportunity to get some answers, including making sure we include more patient-reported outcomes, which is clearly lacking, refining some of the research design and trying to get rid of some of the design noise. I think we tend to see quite a lot in many of the trials and studies published so far. Again, trying to make sure patients' views and attitudes are well reflected, but also professionals' attitudes as well, because I think that was probably something that was quite obvious from the presentations earlier. So we already know, for instance, and it's just a quick example, that although everyone's overall quite positive and enthusiastic about pharmacogenomics, I think there's a hesitation around integrating that into practice. And patients, although again overall very positive and enthusiastic, don't really understand it, are a bit hesitant about what genetic pharmacogenomics means. So there's a lot of work to be done there, I think, on a number of levels. So if anything, I think it's a fantastic opportunity to build on the work that was done. And since we're still refining the trial design, probably a good opportunity for other people to get involved as well and maybe contribute to something that will answer, hopefully, more questions than we even anticipate at this stage. So very exciting place to be in.
Wonderful. Thank you very much, Ramona. Thank you, Emma. As you've got a sense, this is very early days. We're just, it's only taken me just about 4 and a bit months to get the data sharing agreement signed off by our university to Jesse Sven very kindly wanted to share their protocol. So it's taken 4 months to get that piece of paper signed that I can actually now read it and share it with some people. So it's those sorts of things that sort of slow down the progress of these things in some ways. But we're really keen, as Ramona has just said, to speak to a broad community of people over the next few weeks and months to make sure that we get this right. You know where I am if you've got any comments. The slides from today and the presentations will all be available on our website very soon. I'm not exactly sure, but it will take Barbara and all the team a little time to collate it, so it'll all be there. But if there's anything on any aspect of the day that you want to just feedback on, that you wanted to just give us a sense of what you thought, what you would like to see in future events, and we'll see what we can do to make sure that we can accommodate that. Thank you very much for your time today. Thank you for coming to London and sharing it with us, and for your support of our work.